احنا المرة the last time we did a stop before the extra stimulation or what's called the programmed electrical stimulation. So to very quick revise what we do in the baseline study, we insert casters, 3 or 4 casters in different places. We check the signals, the atrial signals, the annular signals A and V, the His signals AH and V, and the ventricular. And then we do retrograde burst pacing or antegrade burst pacing, where we look at the surface ECG. Is it capturing or not? Is it tracking the rate of the pacing or not? Is there any change in the morphology of the surface or any change in the pattern of activation in the intracardiac EGMs? And then we test for decrementality and Wenckebach cycle length when there is no conduction of a certain beat. The next step would be what is known as an extra stimulus pacing. Extra stimulus spacing is exactly the same concept as a PEC or a PVC. The idea of a PVC or a PEC is that I try to bring an extra stimulus faster or backwards in order to test for the refractoriness of a tissue. So if I'm trying to test for the refractoriness of the retrograde conduction across the AV node, so I will test through an extra stimulus spacing from the ventricle. If, for example, my baseline heart rate is at 600, for example, so the train of pacing would be at 500. If my baseline heart rate is at 500 milliseconds, I will start faster at 450 milliseconds. So I will need a train of burst pacing to start with. Usually there are 8 beats of this burst pacing cycle, and then the next beat, the S2, what's known as the stimulus number 2, would be at a different cycle length. So we can start, for example, at 450, 400, and then we drive this extra stimulus backwards. It's going to be 400, 380, 360, 340, and so on. Looking for what? Looking for refractoriness of the conduction system. Or as we have mentioned before, if I am antegrade, it would be an AH jump. Something. تمام. I just decrease the number or increase the rate of the next beat in order to test for the refractory period, as we have mentioned. So we can have an atrial refractory period, antegrade refractory period. It could be even though the refractory period, it could be slow passway or fast passway, and ventricular refractory period. Let's check one of the EGMs. I will start through the first one, and then the first beat, and then I will ask one of you to trace the second one. As we are used to, we'll start with the surface ECG. So we have a P wave right here, QRS complex. It's narrow, and it is looks normal. Then we have a high right atrial caster with an atrial wave on it. There is a spike preceding, so we are pacing from the atrial side. The next casters are the His casters, where we have A, H, and V. The CS casters, where we have atrial waves and ventricular waves. And then the RV caster, we have a V only. So we are pacing here from the high right atrium. But if there is a difference between this train and the one that we have seen in the previous lecture, this beat is not as equal as this train. So this is S1, S1, and this is the S2. And if we can see here on the stimulation channel, the last beat is a premature atrial beat. So this is an extra stimulation programmed, okay? It's a programmed extra stimulation. There is a train of S1, and then we bring an S2 into the strip. Dr. Joanne, can you tell me what we are seeing in this strip during the second beat and the third beat?
Yeah, so in the second beat, We are still basing on type S2. We are
Yes.
talking about the second S1 or the S2? So say
I just
S1.
need to make sure you are following this S1. We have to look
Yes.
at the S1 in order to to know what
Yeah,
happened
that
in
is S1. That is S1.
yes, this is
So
S1 and this is S2.
yeah, yeah. So seeing either seeing the normal say initially AHV in the CS in the his cat castor, and
Okay.
then yeah, I don't see a ventricular. No, in the
So right
I
here,
write ventricular.
this is a normal
Yeah.
beat, okay, with an
Okay. Okay.
AHV.
Yeah.
Okay, let's go to the premature atrial contraction that we give the S2.
Okay.
This is called S2.
Okay. So
Okay.
in the
What happened
S2,
with the S2?
the AH interval for long.
Yes, the AH was prolonged. Uh, how many milliseconds did it prolong? Or is it just a decremental property? Or there is something else going on?
I think it's prolonged too much.
Jump. It's jump.
Yes, it's prolonged too much. And since it's prolonged so much, so we say it is an AH jump. Okay? Type. What we have done right now is somehow wrong. Why are we saying this is somehow wrong? Because we do not compare this AH interval with this AH interval. We compare this AH interval with the previous S2 on the previous run or the previous train. Okay? So if I am
Okay.
giving a train at 100, for example, the S1 is 450 and the S2 is 400, and then I have an AH time of whatever number. It's like مثلا 30, for example. And then I am giving at 450 and 380. Okay? It should be what? It should be 35, 37 مثلا. Okay? And then I'm giving 450, 360. Okay? If this at 360 became 100, for example. Okay? So there is a 70 millisecond jump in the AH between the S2 of 380 and the S2 of 360. So this is called an AH jump. So we do not compare the AH of the S1 or the train with the AH of the S2. I compare the AH of the S2 to the previous S2. Is this clear?
Yes.
Not the
Okay.
previous S1, the previous S2. From the beginning, yeah, you're there.
Yes, from the beginning. So I do track the train in the on the right side of the on the left side of the screen or down in the screen. There are the stimulation that I have made. Okay, so I go down
أنا
bit by
كنا
bit.
كنا بالبيز
Look,
لاين، يعني
Dr.
قارنا
Ahmed.
بالبيز لاين قبل الستيمولس، يعني قارنا بالبيز لاين مثلا.
No, I
For
am not
example,
comparing it to the baseline. That's what I'm talking about. I did say that yes, I can imagine that there is a delay in the AH time on this strip in comparison to the previous S1 train, right? There is a comparison. Can I say, is this a jump or not? I cannot tell if this is a jump or not, except if I see the previous S2. Okay? It could be just decremental. It could only be decrementality without an evident jump. How would I know? طيب, let's check this strip and the next one. Let's go to the next one. Can you see this one? This is a
yes,
more premature PAC. This is a more premature PAC. And this is the AH interval. So I will compare this AH interval to the previous one, this one. Okay? That's what meant by an AH jump. I do not compare it to the the normal train. I do not compare it to the train. The train will keep on 450. So the AH time will be of that of 450. But I do look for the jump between the previous S2 and this S2. So if this S2 was at 380, for example, and this S2 is at 360, so yes, there is an AH jump in both those strips, between both those strips.
How much the difference, please? How much is difference? More than 50?
Uh, more than 50 to 70. Yes, 50 to 70.
Okay.
Okay, so if you look here, this is the H time, and now see where the H is. It's very far. So this is an AH jump. I could never tell on a single strip. In order to say that there is a jump, I will have to see two extra stimulation strips. That's the point from those two strips. Okay? Okay. طيب. In this strip, Dr. Ahmed بقى, you can go through this strip.
Yes, we have a retrograde basin from the RV. It
Yes.
capture the ventricle wide QRS, spike for every QRS. We have first basin looks the same cycle length,
Okay.
not first basin. The activation, the inlet signal through the C9 and 10 with concentric
Yes.
activation.
Perfect.
But
Okay.
basically, okay, and when we look for the VA time, because it's so great to see the VA interval, okay, looks the same.
Okay, so it does look the same, but the stimulation looks the same as well. So we are not going
Yes,
faster. So it will be the same. Okay,
yes,
let's go to this.
very
This is
good.
the end of the strip. After I
Yes,
did the same train, I have one extra stimulus here. Okay,
okay, yes. VA, yes, VA, prolonged. This is the prolongation of VA time, the last basing.
okay. So this is a BVC, okay, from a retrograde extra stimulus. I did have the train, as we've mentioned. So this is the train. This is the regular conduction of this patient at a specific cycle length. And then I will give a PVC. During the PVC, yes, you have mentioned that the VA time is different. I do compare it to mean برضو the previous PVC. We could say if this conduction would be decremental or non-decremental. Okay, so this is decremental because on faster cycle lengths there is a prolongation in the VA time. The second thing that we look at, the pattern of activation. Did the pattern of activation change during this PVC or it is the same?
No, no, the same. The early signal is C9 and 10.
Yes, it is the same, so there is nothing going on. Okay, we will continue. This is
But so one.
Hi, Dr. Ahmed. What do you think about this trip?
Okay. There is this, we have a basing from the RV, this the RV there.
There is no pacing spike.
There is a basic spike.
CS
No
7
Joanne,
and
Joanne is saying something?
in CS. There's no. I thought the spike is in the CS 7 and 8, but I'm not sure.
The first step, look at
Oh,
the ECG.
okay, sorry. Okay.
Okay, is this ECG paced from the ventricles?
Lead one is the lots of artifact.
Let's look at V1. Let's look at V1. Is it the same as this one, Dr. Ahmed? Is it
no,
wide
not
and
so wide.
captured?
Not so wide.
No,
There
it's
is no
not.
spike.
It's not wide. Okay.
Yes.
طيب
This
again we said
tachycardia,
we have to go through yes, this is tachycardia. Why did we say that this is tachycardia? The first thing we said,
our
compare the A's and the V's with the surface ECG. Know where is the V, where is the A, and then we think, is it pacing, is it tachycardia, is it sinus, and so on.
yeah,
So this is the surface QRS. So those are the V's. Okay, this one is the V, those are the V's. And then those are the A signals.
A's and
So
B's close relation to each other.
there is what?
Close the V to A. The A signal and V signal very close to each other.
Where? At which signal?
Coronary sinus distal. I
Okay.
can't.
So right now I'm having a tachycardia, okay, with 1-to-1 VA conduction. It is a long VA time, okay, right? From the surface QRS to the A, it's long. And the earliest retrograde A is at CS distal or 3 and 4. This is the earliest, right? It's not CS proximal. It's not CS 7 and 8. It's not 5 and 6. It's 3 and 4. Okay?
Yes.
So this is a pattern of activation which is
Eccentric.
eccentric. So this tachycardia uses a left-sided accessory pathway. It's
Yes.
a narrow complex tachycardia, okay, with long VA time, with earliest pattern of activation at the lateral CS catheter. This means that we have a left accessory pathway. تمام؟
NVRT. Most likely.
AVRT. I will change the PowerPoint. Okay, can you see my screen?
Yes.
Okay. Type again. This tracing, we have
Yes, we have a basin
pacing, okay,
on the RV.
from the RV with a VA retrograde conduction. And right here, the same patient, what happened to the VA time?
It looks the same.
It looks the same. It's the same patient, this strip and this strip. There is decrementality, Dr. Ahmed, right? This is the
Where?
spike, this is the V, and this is the A. So this VA time is different from this VA time.
Yes, indeed. Yes.
So when I increase the train cycle length, I decrease the cycle length and increase the rate. There is decrementality, retrograde decrementality. And then what is this called? I'm going faster. Okay, what's this called?
V without A.
Yes.
Block. والكباح cycle length.
Yes, it's a retrograde Wenckebach cycle length. Okay, so when I did the start, it was the 1-to-1 conduction with a very short VA time. When I increase the rate, there is a VA decrementality. So I'm going back through the AV node, and my earliest A is at the CS proximal. The pattern of activation is not changing. And then
Yes,
I
we have a
did
V without
decrement
A.
again until I did not conduct. This is the retrograde Wenckebach cycle length. Okay, تمام. Let's look at this tracing of this patient The patient that I just showed you with the tachycardia with the long VA time and earliest retrograde at the CS3 and 4, the strip on the right. This
Yes.
is the same patient during retrograde pacing. This retrograde pacing was going back through which AV node or accessory? This retrograde
The
conduction.
earliest activation.
Accessory.
Sorry, Joanne, I didn't hear you.
We look the earliest activation. Look the coronary sinus proxima.
Okay, Joanne, what were you saying?
I was saying, so the pacing is in the RV,
Yes,
and it is going back. It's earliest in 3 and 4.
on the right or on the left?
So this is likely on the, so it's V1 is negative, right? It's likely on the left.
I can't
Okay,
hear
so
you very
just a minute. Yeah, so what I'm saying is you're pacing from the RV,
Yes,
right ventricular. So it's I can see the spike, and later on there's a retrograde A, like VA.
yes. Where's the earliest
Earl-
retrograde A?
Earliest is at CS 3 and 4. 3,
No,
4, 8,
in
3.
this
No?
strip?
CS 3, esto, proximal where? Really?
I will put a line for you.
Put
Okay.
a line for me because I think maybe my eyes are not good. So
Look at this line, Joanne. This is at the beginning of this A wave at the CS proximal. So the CS proximal is the
where's the
earliest.
line? Where's the line?
It's on the
Oh,
screen. It's not
sorry.
on the.
Oh, sorry, because I think I had two my screen, so I wasn't seeing this left screen.
Ah, you were on
Okay.
the other side.
Okay.
Okay.
Yes.
The other
Yes,
side, the Joanne,
yes,
is the same
yes. So,
tachycardia that we just saw.
yeah, okay.
Okay. So that's what I am
So
talking
they
about.
get
It's sometimes we
Okay.
do pace from the right ventricle, and the retrograde conduction is through the the AV node with earliest at CS proximal, and then it's decremental, and that it's going to Wenkebach. Okay, and still we
Okay.
have an accessory pathway on the left side. Okay, it was apparent during the tachycardia. So in those cases, I will have to make extensive stimulation. I can go stimulate from the left ventricle. Okay, because the right ventricular retrograde conduction does not reach the accessory pathway on the left side. It only goes back through the AV node, just like this case. So we will need, whenever I have a tachycardia like this, now I know that this retrograde conduction at this screen and the previous one, this is the same patient. I will show you the previous tracings. So as I go faster with the pacing train, it was decremental and it did Winkebach prior to changing the pattern of activation. So the RV pacing was not able to go retrogradely on the accessory pathway, although the patient had a clinical tachycardia with eccentric pattern of activation. Okay.
can we base of through the CS LV through the CS or
We talked about this before, Dr. Ahmed. Regularly, the CS does not capture the ventricle. To capture the left ventricle, it has to be on in one of the branches. Okay.
Yes.
So we go either retrograde arterial, or we do map during the tachycardia. Okay, so in this strip, if we can see here from the ECG, up here he's saying that the S1 is 600, the S2 is 400. So this is an extra stimulus, retrograde pacing. Why did I say retrograde? Because the surface ECG looks white. The
Why?
surface ECG looks wide and the spike is
Why
at
called RV?
RV
RV?
caster. Okay. And here he is naming all the signals, which is the V and which is the A. So if we can see
Yes.
this strip at the proximal, at the distal hiss, there is a very early A at this hiss. Okay, there's a very early A at this hiss. Okay, then we have, as I have mentioned before, some labs do the CS arrangement opposite to ours. So we have to revise where is the CS proximal and where is the distal in order not to get confused if this is eccentric pattern of activation. It's not, because the earliest is at the hiss, okay, as we can see here in this A.
Yes.
And then in this extra stimulus spacing, I can check what happened to the VA time.
Yeah. Okay.
Eh?
It
There is a
increased.
slight
Increases.
decrementality. Okay, there is
Slight
a
decrementality.
slight decrementality, very small decrementality, and there is no change in the VA time. Type. Let's go to this strip. Same patient,
More
but
broad.
the PVC is more premature. As we can see up here, it's 260. Okay, the cycle length is 260. What did happen
Increase
here?
the VA time. Increase the VA time.
It's so much prolonged. Yes, it's the V2 to the A2. It's so much prolonged. Can I say a jump or no jump? I can't say a jump or no jump. Why? Because this is
Compare.
400 and this is 260. I didn't see the 280 or the 290 or the 300. I didn't see. It has to be with mild decrementality by 10 or 20 milliseconds only that the VA time increased more than 50 or 70 milliseconds. So this just shows us that it's decremental, but it does not say jump or not. Okay? Did the pattern of activation change? That's the second question.
No.
I always ask myself,
No.
is it captured? Yes, it's captured. Is it decremental? Yes, it is decremental. Is there is pattern of
Consensus.
activation change? There is no pattern of activation
Consensus.
change. Okay,
Yes.
so I'm going back through the EV node until now. Type. Look at this one. The S1 is at 500, the S2 is 360. So I
We
have
have a
here a
V
spike.
with
Yes, a spike, a V. Why did I say this is the V? It's coinciding with the surface. Okay, and then an A here. Where is the earliest retrograde A? At the His proximal. Okay,
yes.
so this is this is concentric. What happened here in the second beat?
وانتباه ساكن. وانتباه ساكن.
لا, it's not called Wenckebach cycle length. Same
We have a
idea.
V without.
Yes, there is no retrograde conduction. Rowan, what did you say?
بقول effective refractory period.
Yes, effective refractory period. So Wenckebach and effective refractory period both look the same on the EGM. A beat which is non-conducted. If this beat is
Yes.
non-conducted after a burst pacing or a train, this is called Wenckebach cycle length, either antigrade or retrograde. But if this beat is not conducted because it is very early, because it's an extra stimulus, okay, it's an extra stimulus, so it's called the refractory. So right now, the ventricle did capture, but the atrium was refractory because I was so premature. So the atrium did not, the beat did not conduct. And it's not the atrium that is refractory here. I mean the conduction, the AV node is refractory. So this is the retrograde effective refractory period of the AV node. If I do give a spike and there is no V, so this is what is refractory. If there is no V, a spike only,
Ventricle. The ventricle.
the ventricle itself is refractory. Okay, so if I give a V, if I give a spike and there is no V, the ventricle
Not
is
captured.
refractory. Yes,
mean
it's
not
non-captured because it's refractory. Yes. If I give a spike and there is a V without an A, it's called effective refractory period. If there was a jump, The jump
Mm.
is the cycle length, the refractory period of the fast pathway. Because the fast pathway did block at this specific extra stimulus, and then we jumped to the slow pathway. And then after I jump to the slow pathway and there is no VA conduction at a certain point, this is the effective refractory period of the slow pathway. If I do not have a jump, we call it effective refractory period of the AV node. Is it clear?
The last point, please. The effective refractory period of slow pathway when which?
Okay. Type. I will check if we have tracings for this, and if I do not, I will explain it to you, Dr.
Okay.
Okay. Type. Mm, what's going on?
What is this PVC?
Let's go from the ECG. This is narrow, right?
Narrow and then wide
Narrow.
without spike.
This is a P. So those are
Yes.
the A's. Those
The
are
A.
the V's. Okay.
Yes.
What's wrong with the V's?
The Ellis activation through C1 one
Yes. So this
excessive.
is a sinus beat, which is pre-excited. Okay. And the earliest activation is at CS1 and 2. What's this?
Uh, what this is wide QRS. Wide QRS looks wide. Left bundle. دكتورة Rana.
Sorry, Dr. Ahmed, I had an internet disconnection.
أنا ودكتورة جوان بعضنا في نفس التليفون أنا إنها فصل.
Okay.
تمام.
Okay. Okay. Type. Sorry, I had a disconnection. So the first beat is a sinus beat with
Fine.
manifest conduction through the accessory pathway. The second beat is a PVC, right?
Yes.
It's a very early PVC. When I had a very early PVC, this is the V's, and then what do you think about the A's? It's still going through, or it's still retrogradely conducting through the accessory, because the retrograde conduction, so here the antigrade conduction is through the accessory, and the retrograde conduction as well is through the accessory. The atrial pattern, retrograde A's are on earliest at the CS1 and 2. What's this beat? It's another BVC with also what? Retrograde conduction across the CS1 and 2. This is important because sometimes the sinus beat itself looks normal with normal pattern of conduction, and the PVCs are the ones that show us that there is an eccentric pattern of activation. So we have to always check the spontaneous PVCs to make sure the pattern of activation is not changed. Okay, let's skip this one. Okay. Right here, we do have a strip. It's narrow on the surface ECG. We have a spike at the high right atrial cluster, S1, S1, and there is a premature atrial contraction with an A, H, and V. And here, during the antegrade conduction, A, slightly prolonged AH time, and a V. It's clear. Let's check the pattern of activation on the CS casters كده.
The last V1.
They look the same, but let's put a line to make it easier. Sorry.
The antigrade you look still the V's, huh?
Yes, I do check the V's. Okay, so the earliest is at the his. Okay, at the his. Sometimes it's difficult to do it with our eyes without measuring. We always put the cursors. طيب let's go to this strip. Sorry, it's somehow blurry. I will help you through it. We do have narrow complexes on the surface ECG. Okay. This is the RV where the signals, this signal is and through the QRS, so those are V's. This is the His caster. So I only have an H and a V. I don't have this is an A, this is an H, and this is a V. This is the A, this is the H, and this is the V. Okay. The mark that he is putting on is the AH time. Okay, this is the AH time. And this is the CS caster with an A and then a V. What he is marking is the AH time. Is there any premature beat or something in order to say this is a jump?
What to compare? Previous one.
Yes, we will need to compare another one. ماشي. طيب, let's check this one. This was from Dr. Bayoumi's online lecture. It's a very nice one. So this is an A. This is an A spike. You can see the spike on the surface ECG. Spike, a V. Okay. Spike, a V. Spike, a V. Okay. This third spike, can you see where this spike come? It came during the ventricular depolarization. So this PAC was very premature. Okay, so this is an atrial spike, atrial spike, atrial spike, and this is the S2. If we can track this one, this made A and V. This made an A and V. This made an A and V. This did not conduct. Why it did not conduct? What's refractory here?
The atrium.
The atrium itself is refractory because it was a very, very premature PAC. It did not conduct. Okay, so this is atrial refractory, same as ventricular refractory that we have talked about. Okay. طيب, I will share my screen. Okay. You can see my screen, صح?
Okay, so that's it.
Mm.
عايزين الانترا كارديا تيجي ديما الورقة الأبيض سهل.
Dr. Ahmed, I can't hear you, I'm sorry.
ديما الانترا كارديا تيجي لما يكون أبيض يكون سهل، يكون حاجة صعبة يعني. انترا كارديا
عايز
ملون.
التاكيكارديا ECG؟
لا، عايزين المعقد الملون. الأبيض سهل، واضح إنه يتجمع كل حاجة مكتوبة.
ما هي في حاجات بتبقى مكتوبة بس المهم احنا نقراها لوحدنا. طيب. Again, let's go through it by ourselves. It's better. يعني sometimes the annotations help us, but we have to go through lots of tracings in order to make it easier for ourselves to read. Again, right here, this is a P wave, this is a QRS, a P wave, a QRS, and this seems like a extra stimulus, this one. And we have an AHV spike, A, prolonged H and V. As we have mentioned, I will not compare this AH time to this AH time. I don't care about this. I do care about what the previous and the next. So this is the next, where the extra stimulus is here more premature. What happened to the AH time? There is a jump, right? There is an increase in the AH time by more than 50 milliseconds.
60.
Yes, 60 milliseconds. So this is an AH jump. طيب, this is الحاجات الصعبة اللي دكتور أحمد بيقول عليها. We didn't talk about this فيعني let's we didn't talk about the previous ones let's see this tracing on the surface ECG we do have tachycardia, narrow complex or wide complex.
Not a complex.
Okay, let's check the signals. We have a high right atrium with an A. The His is not at the His. Let's see the His distal. يعني. Okay, there is a small V, a small H right here. Type CS distal, I mean CS casters. We have a V's and the A's. What about the pattern of activation here?
The A-list pattern with the distant. I mean, 1 and 2 eccentric.
Yes, at 1 and 2. So this is a narrow complex tachycardia with a long VA time. Why did we say it's a long VA time?
The B is A is not
We
close
start
to each
from
other.
that surface QRS until the earliest A. So we need to put two marks, one at the QRS, right here,
Mhm.
okay, and another one at the earliest A, which is this one, 1 and 2 and 3 and 4. Okay, we have a very nice potential and fractionation at CS3 and 4. So this VA time is as a longish VA time. So this is a narrow complex tachycardia with a long VA time and eccentric pattern of activation, right? So most probably this is a AVRT utilizing a left-sided accessory pathway.
We have to do maneuver to distinguish.
Of course, we have to do maneuvers. We will talk about the maneuvers بقى. Next time, I just wanted to make sure you can go through the tracings yourselves. طيب, what's
Yes.
going on here? Joanne, please, can you answer?
One.
Yeah, so I can
Take your
see
time
the
through the
sub.
step.
So I can see the sub ECG is trying to see whether there is any pacing spike, but yeah, I can see a P and a V narrow complex,
Okay.
and I think we are pacing from the eye right atrium,
Yes.
and I can see the corresponding A and V. Okay, like is you can see A, H, and V in the
Yes.
His catheter, and then there is so they see there's S1 and S1 and then S2, I believe.
Yes.
Like this is
S1, S1, and then an S2.
and then
That's
S2,
correct.
yes, yes. And
Okay.
then when I see the corresponding uh AH time,
Mm-hmm.
slight increase, but I'm not going to compare here.
Yes. So it is prolonged. Okay.
Prolonged,
I do not know if this is a jump or not unless
a
I
jump, yeah.
yes,
I
but there is a
compare with
clue.
another one.
There is a
But there
clue
is
that this is a
another
jump.
a jump here because
Yes, because
there's a
what?
next bit that is that looks like a native. It's not a
And
paste
what?
native, like it's a native stimulation,
Uh, Okay,
like
if you can
a
look here at
PVC.
the high right atrium, this is not
Uh-huh.
paste. You are
Yes,
correct.
yes,
It's not paste.
that's what I'm saying. Native QRS.
Yes.
Uh,
It's not native, but it's not paste. But it's at the same time of the QRS complex, but it's still on the high right
so
atrium. So
it
this
could
is an
be a
A.
PVC. An A.
No,
Oh, okay.
this is on the high right atrium, right?
So that is the echo bit, like it's combined.
Yes.
And
This
then,
is the
and then
echo beat.
now, mhm,
Right. So now I
okay.
do have A, H, and V, A, H, and V, A, prolonged AH time, probably on this beat the first time, or this is the second one with an AH jump. And then after this V, I do have another A, which is not supposed to
Okay.
be here. Okay?
Okay.
Why do I say it is an A? Because this is how the A's look like.
Okay.
See?
Okay.
The previous one.
Mhm.
So those are A's overlapping with the V's. The echo beat is the one beat of even RT. You know that the even RT have a very short VA time. The V's and the A's are overlapping each other, so we can see them as a single. We could see them as a single signal. But the clue here is that I'm sure that this is an A because it's on the high right atrium at the same time
Okay.
of the V. So this is an AH jump with an echo beat. But the tachycardia did
Okay.
not continue here.
Yes.
It's a very
There's
common
because of
finding because now I know that we have an accessory pathway which is a jump, I'm sorry, a slow pathway which is able to retrogradely conduct through the atrium ويعمل echo and can cause an echo beat. طيب if we check the next بقى uh, this one بقى look Joanne, this beat is the extra stimulus, the third one. This is the S1, and this is the S2. It did the same thing. This is the echo beat, okay? So we do have AHV, AHV, A, jump, echo,
echo beat.
and tachycardia.
Tachycardia began.
Yes. So this is a tachycardia with a short VA time. Why are we saying a short VA time? Again, as we have done through the previous tracings. We have this line, and we have another
نايمة الدكتور.
line, the earliest A, which is here. This is the earliest A. So we have a short VA time. The earliest A is at the HIS, which is the typical for a slow fast even RT, with somehow overlapping. It's not يعني 100% overlapping, but this is a short VA time tachycardia induced by an AH jump, then an echo. So this is more suggestive of even RT, and of course I will still do maneuvers to confirm this is even RT. So at one time I see a jump and echo. Sometimes it's only an echo, sometimes it continues to have tachycardia just like this.
I have a question.
Sure, Joanne.
What is your usual like normal VA time in terms of milliseconds?
If it's less than 70, it is short. More than 70, it is long.
So the cut point is 70, not 50. The cut point.
30 is the one for even RT, and most probably even RT is very short, very, very short. The AVRT is considered a short RB tachycardia. Okay, the AVRT is considered a short RB tachycardia, but it's less than 70. More than 70 is a long RB tachycardia. It could be a typical even RT, it could be BGRT, could be atrial tachy. Okay. Even RT most probably is very, very short, just like this one. This is an atypical even RT. That's what it's called. Let's go through the tracing. This is a tachycardia with a narrow complex surface ECG. We have a V, then an A V, then an A V, then an A. But right here, the VA time is very long, as you can see. We start from the QS, and we go to the earliest, is at the HIS or CS proximal. CS proximal is the earliest. Okay, we have a VA time of 150. Let's go through more. Okay, Joanne, can you go through this strip?
Yeah, so if this is a wide complex URL,
Yes.
likely retrogradely, it's being faced from the RV, so RV facing.
Okay.
And you can see the facing spikes and where you can see the time where
We do not check the VA time, Joanne.
Oh,
If we
okay.
are no, I
Getting
mean
from the
we do check the VA time in case of to see the decrementality, but it's
okay,
not a wide complex tachycardia. It's a
a
wide
pace.
complex spacing,
Okay.
and the third beat is a PVC.
It's a
It's an extra
PVC,
stimulus.
extra stimulus.
S1, S1, S2. Okay, let's
Mhm.
check the what we said. Is it captured?
It's captured, yes.
It's captured. What's the pattern of
Yes.
activation?
So the pattern of activation now is we are seeing the earliest A at PS1 and 2.
Atrial activation. The earliest atrial.
Atrial is at 1
Yes.
and 2. So it is eccentric.
On which beat, Joanne? Where are you? Where are you looking, Joanne?
Okay, so I'm looking at after the premature pace,
Why are
like
you looking after?
extra
You should
stimulus.
look.
Okay.
We do start the strip. We do start.
Oh, okay.
No,
Okay.
it's okay.
Okay.
It's okay. It's very important to go systematic. I mean, we
Okay.
can start on the right, we can start on the left, we can start
Okay.
whatever.
No.
Just get a hold of which is which, or where the beats
Okay.
are, or where the V and where is the A. And yes, we can then say yes after
Yes.
the pacing. There is something weird going on. Okay,
Yes. So
I can agree with you. So during
initially
my retrograde pacing, when I
you
was
saw the
retrogradely pacing and capturing, there was
it,
a VA conduction. It was fine. And it
yes,
was concentric. It was through the
concentric
AV node, and the earliest was at the HIS and the CS proximal.
yes.
But this PVC did not conduct through the AV node. There is a
Mm-hmm.
reversal of the pattern of activation from the second to the third beat. The pattern of activation was reversed from concentric into eccentric,
Yes.
right?
Yes.
This is the first tachycardia beat. This third extra stimulus, the third beat, the extra stimulus is the first tachycardia beat, and then the tachycardia continued with a long VA time. Can you see the VA time here? So if we do have this
Yes.
line, okay, and I have the earliest right here. So this is a long VA time tachycardia with eccentric pattern of activation. It's very clear the reversal of the pattern of activation from the retrograde pacing, the PVC. In some cases, the only clue is this PVC. It does not conduct or continue tachycardia. But a single PVC during the tracing can give me a clue that there is an accessory pathway, left-sided accessory pathway. In this case, the patient got the tachycardia, so I have a continuous beats and continuous tachycardia, I could see the pattern of activation, but sometimes the only clue is a single VVC. Okay. What's this tachycardia?
Mm.
Classic. The classic.
uh, V was even RT most likely, narrow VA
Even
time.
RT?
Huh?
Yes, even RTY, because the V's and the A's are overlapping. Those are the A's, okay? Those are the V's, and they are overlapping with the QRS complex. There is nothing in between, right? So a very short VA time. Why do I call it very short VA time? Again, this is the complex at the same time of the A, okay, right? So the QRS complex, it's almost the VA time is zero here.
Yes.
The atrial waves are at the same time of the QRS complex. So this is a typical AVNRT. Okay.
I have a
When we
question.
Mhm.
So it's just how you know it's a bit how you know there is supposed to be a fuse in your
How can I
in a high retro caster, like you assume that's why you should feel the P,
I
right?
can't hear you, Joanne. I'm sorry.
I'm saying you can hear me now. Hello.
Yes, I can hear you right now.
a masking. So it's just by looking at the clusters that is when you assume that the P was supposed to be in highlighted on cluster, right? Because